Hello, and welcome to the new episode of the Digital Innovator Circle podcast. It's my pleasure today to have Dr. Bhatt, Chief Innovation Officer at the American College of Cardiology. Um, Dr. Bhatt is many things. She's a national leader for creating an AI-enabled clinician. She's a true innovator in cardiology with more than 20 years of experience in cardiology and also a decade of experience in digital health and telemedicine. And she also chairs the FDA new Digital Health Advisory Committee on that topic. Dr. Bhatt, welcome.
Thank you. Thank you for having me.
All right, I'm excited about this interview, and I would love to first ask you a question. That was the first question on my mind, which is ACC is one of the rare associations that has a formal Chief Innovation Officer role. How did that happen, and what was the driver behind it?
Yeah. The role began actually 7 years before I joined, so about a decade ago now. And really the thought behind it was very forward looking. I can say that because I wasn't part of the thought process at the time, which is that the delivery of healthcare was definitely going to change. We were starting to see a lot more remote monitoring, which, in cardiology, we've always been very remote monitoring forward, more digital health, more use of data analytics, right? The algorithms that precede the concept of AI, if you will, and an increasing interest in care at home. And so those four areas became the pillars of the ACC Innovation Program. The thought was there are a lot of early companies thinking about this area, focused on this area. How can we help them better understand what cardiologists need, what our patients need, how the system works, such that the technologists would get a better look into what it's like to not only create the technology that we need, but create a technology that can be implemented into the workflow. And so that's kind of how it started. COVID happened right in the middle of that. I was still at MGH during COVID, and when we changed fully to telemedicine in about 48 hours, we were able to get an increased number of patients seen in the subsequent years. It was a great opportunity. But that really opened my eyes to how much better we could offer access, right, to patients if we change the structure a little bit. And so that kind of took me in my course over to the American College of Cardiology. And since I've gotten there and our team has grown, we really focus on three areas now. And it's a natural transition from where we started and why we started. The first is really to say, how can we improve patient outcomes in the communities where people live? What are the technologies that get us there? What is the infrastructure and what's the education we need for clinicians, for caregivers who may not have been trained as clinicians, and for patients, right? So that's the first. The second is how do you really create now the AI enabled clinician? Because AI has been around in the form of machine learning, especially in radiology and imaging, but generative AI has really changed things. So, how do you create the AI enabled clinician? And then I think probably that the last thing for us is how do you help these technology companies, the investors who are investing in these technology companies, all understand what does it look like to really have a workflow that fits more than one model, to have the ability to have an infrastructure that can not only exist at the upper echelons of academic tertiary care, but really in the areas that need that access the most. And so that's kind of where we focus our time now and why we exist.
Right. That's really powerful. And, I remember back at my time in pharma, I worked in different areas, and cardiology was always one of the specialties that was leading the way when it comes to innovation. And so it doesn't surprise me in the way that the ACC is one of the leading associations to formalize the role, and especially with now with the AI enabled clinician, of course, last 2 3 years since AI exploded even more. And how much does what you do relate to the innovation per se of how associations operate and how ACC operates in
Yeah.
general?
We at ACC really think of ourselves as one unit. And so I think one important paradigm across healthcare, definitely in our company, is that no one exists in a silo. You can't have innovation is here, global health is here, advocacy lives here, science, lives over. You can't have that. You need to have conversation and an interconnect. And so even though we may be the innovation program, I think the word in a way is a misnomer, as the word innovation is actually in the mission and value statement of the ACC writ large, which is we are always looking as to how do we make sure to continue to do better than we've done before. for the sake of our members who are clinicians, administrators, caregivers, and our patient outcomes, which is, the other reason that we exist.
Well, that's great. And then could you share? I'm sure there are a lot of examples, both in cardiology and the association side. Any of the examples of any of these across three areas that you mentioned that you would like to share or zoom in a little bit more?
Yeah. If we think about, let's go to AI because there's so many areas to think about, right? And we can use the other concepts as part of that example. There's administrative. And, most of our associations are really thinking about our members and what can we do to reduce some of that administrative burden that they have to be able to allow them to do their job better. And so, for example, one is the idea of voice to text technology. We were kind of early to the game in thinking about who are these technologies? How are they functioning? What do we need from them such that you can just be with your patient, have a conversation, and start to have some of the logistics done for you in terms of writing the note. Now, the important part is not, hey, the note got written, right? The important part is the clinician, yes, is able to focus on their patient while some of that administrative work is done. They do need to still review that. Collaborative intelligence is what we call it. You can't just say the AI did it for me. But the best part is that can be translated into an eighth grade reading level because this is Health Literacy Month. October is Health Literacy Month. And it's so important that our patients understand the discharge instructions we send home. How often do they not understand what we sent them, right? We can translate into multiple languages simply because we use a large language model means we can translate. They were, in fact, originally large language models were created in the process of translation. And now we're using them for a lot of other things. And so I think a lot of that gets back to this idea of getting care to the areas that need it the most and the people who need it the most. And so I think that's kind of one example on the administrative side. I think the clinical side is very interesting. Machine learning has been around for a long time. And the idea of AI being able to be an assist and say, hey, I see the following. Now, here's the thing. We used to say, hey, I see the following, like I've been trained on 1,000 x-rays and I see a pneumonia here on left lower lobe. And so I know that's what it is. And that's kind of the traditional machine learning that people are comfortable with. Now I can tell you, you have a low left ventricular ejection fraction based on your EKG. For those who aren't in this field, that is not something that the human eye can see off of an EKG. There is something about all the reams of data that go behind that is able to tell you that. And so the area we're entering now is an area where, especially as we start taking more data, some EHR data, some imaging, some about the patient, some social determinants, right? It's not going to be as explainable. And so this area is really important to me. It's where we spend a lot of time working now, which is how do you ensure that companies are transparent and where they got the data and what they're doing with it? And how do you determine that outcomes are better than they would be without it and continue to be good and safe, even if the algorithm is changing, even if the base model is changing. And so transparency and outcomes now becomes really important for clinical AI compared to what we used to think was explainability. And we really got on an explainability train, but realistically, that's not going to be as possible. And so that's another area where we're working closely with a variety of companies, and tend to not like to just name companies on podcasts only because for every one company I know, there's probably 49 others who are trying to do the same thing and probably doing it well. I just haven't met them yet. But the idea is right. How do you take multimodal data and help a clinician understand who's sick from not sick? How do we triage? Not here's the intricate care that 35 years of training tells you should do. It's not there yet. But some of this early access, who needs to go where for what type of test, that's the kind of work that we're doing. So administrative in the office, clinical like this, I think two areas. And then population health is the last one. We can do so much screening and diagnosis work. We can find patients who have certain diseases so much earlier, but the caution is we have more and more patients, fewer and fewer clinicians to provide that care. And so if we're going to find more patients, we need to give people an infrastructure to bring those patients in. We can't just say, here's a deluge of patients. We need to say, here are more patients and here's how we're going to figure out how to care for them. And that then pairs with education, educating clinicians, educating patients for more patient agency, educating community health workers to serve in the triage roles. And so I think those are kind of three of the areas that we're going for right now.
Oh, thank you for sharing that so clearly. And just listening makes me think how exciting is this time that we live in. First of all, that the plenty of data that you mentioned, how all of that can be used in the right way to actually give a much better picture of what's actually happening with the patient and improve workflows and increase access for more and more patients. It's really powerful. And I used to play chess, by the way, professionally. I remember Gary Kasparov, who wrote first few books on AI, and AI has been better than human in chess since '97. And I had the pleasure to see him in person here in New York. And one thing he was always saying, man and the machine always beat the machine. And that happened in chess as well. And I think that clinician plus the machine or data and AI and all of that to go compute, it just beats the machine. And that's like
Yeah.
really powerful to think about.
Yeah. Can I counter my own statement now since we're sounding very
Yes,
positive?
please.
There are a lot of potential negatives, right? So if one is if the data is not good data, we're in trouble. And so, we don't necessarily have comprehensive data that represents all the people, right, that exist right now. And so there's a lot of work we need to do to make sure that the data sources we're using are actually sources that are going to help the people who need it the most. And so I want to clearly state that caveat that we have work to do on the data front. I think the second kind of challenge is people worry if you start using AI all the time, will you no longer know what to do without AI? And there was a study that came out a few weeks ago about, I think it was GI doctors doing colonoscopies, and it was kind of image guided and aided versus not, with AI saying, "Hey, is this one adenoma? Is this a polyp?" And the simple story is, in that one limited study with all the things that were going on, there was a suggestion perhaps you become dependent on it, and when it's taken away, you're not as good. Now, I have not read the GI part in depth, and I have a bunch of GI doctors on my, text chain saying, "Hey, when you read it, tell me what you think," because that's really what I want is the expert to tell me. But I do think we need to figure out, when do you use AI? There are times where it would be a waste for you to use AI because you are so expert that just doesn't make any sense. There would be times where somebody knows so little about a topic. If you come to me and ask me about a knee, I should not be going to AI. I should just be saying, "Nope, can't do knees, not qualified to do an I need to refer you." And there should be no AI involved in that either. And in between is the primary care doctor taking care of a heart failure patient who's a new diagnosis, early stage. Unfortunately, we end up a third of the heart failure patients are somewhere living in the primary care world, right? Either outpatient or inpatient. We do need to be able to help people take care of them for those initial steps before we can get them to where they need to go, if we even have enough clinicians to care for them. So, how do you use AI? When do you use it? When do you not? That's a really important discussion that we should have as societies moving forward. And we should think about, when do we want to use AI? When do we not? Not just assume using it all the time is right or never using it is right.
Yeah, 100%. We should somehow with it become smarter, not less smart and capable. 100%. And then, there are all these innovation happening in cardiology, and a lot of the companies you're mentioning, they're tackling all kinds of things from diagnosis to everything else. And so, what is the role then of the ACC and responsibility specific? Something if you can share an example, is it provide like what associations traditionally do, which is trusted place to educate, scientific and clinical guidelines and guardrails. So, what are the some of the roles from your conversations about this topic?
Yeah. Let's just broaden out from ACC specifically to societies, right? What is our role? So, I think first and foremost is, what do our members need, right? Because we are member societies by and large. So let's start there, always knowing that patient outcomes are, the reason that we all do our work, but specifically our member societies. So in the setting of being a member society, our clinicians need education, first and foremost, not only about the topic at hand, but also about how healthcare is changing. The rate at which the technology that is available is changing and affecting care is significant. And so we really need to have our clinicians not be expert in each of those unless they want to, then we should probably start to create some training pathways, but to be able to live in a world where change is a constant, especially when it comes to the technology you apply to your patients. If you think about any of our fields, you have a device, it gets FDA approval, it's in trials, people get trained to use it, and you use it the way you were trained to. Once in a while, there's kind of an exception case that somebody, really talented will use it for. The current technologies we're talking about are coming quickly, People are trying to implement them or figure out if they can use them. They might be changing rapidly. Software is being updated. And even the novel AI mechanisms we're using, large language models may be out the door soon. We may have RAG and small language models. We may not have them at all. We may have world models and all these other things that meta AI scientists are talking about, right? So there's a lot of movement, and you need people to feel confident that somebody knows what's going on, is watching, is teaching. And teaching can't just happen in terms of teaching. You can't, I can't take talented AI engineers, take that data and be able to teach the world. Like, that's not how it works. I can talk to them about what we need. And then my team and I and other teams from other organizations can go out to our clinicians and say, here's what we're seeing. What are you seeing? And so that's the second part, which is I think associations have a responsibility to say, hey, so and so's trying this. They're doing a great job. Or, hey, this group tried this and it failed for the following reasons. We need to be the connector that shares what our practices, health systems, individual providers are doing, when it's working, when it's not, and create really that network of communication, because this is moving too fast for us to do in silos alone. And we haven't done that yet. We're moving towards it. We have programs that are trying to make that happen. We do need industry funding sometimes to make these kind of programs happen. So that's where we reach out to industry colleagues and say, hey, in order to be able to find more of said diagnosis for which you have an excellent treatment, we need you to educate patients, educate clinicians, help us build an infrastructure, create a network. And so I think that's some of the work that associations really could do. It is education, but it's actually taking the knowledge that's coming from different silos, pulling it together, and creating forums for people to be able to continue to improve upon their practice.
Yeah, and it's interesting this you're saying that, and I'm thinking there was this study 2 weeks ago. It's not related to medicine, but it was related to business. I think it was from MIT, basically saying all this excitement about AI pilots in large enterprises. 95% the pilots haven't yet proven the value. It's an interesting, right? And five have done. And I'm like, okay, in medicine, like you take that. I'm like, okay, we have to be really careful. So when we say use something, then it has passed all the safety measures. So if in business is 95% didn't bring value. So it's kind of, I expect to be a little bit more cautious. And then when the real use cases come up that are powerful, they say, okay, now this can go into the usage. And I assume that those are kind of discussions that you also have in regulatory bodies and the boards that you sit in FDA. So it's
Yeah,
done properly.
the use cases are essential, but the ability to scale a use case is different than the use case. There are a lot of great use cases that, for a variety of reasons, whether it's clinician preference, patient location, type of practice, or fiscal bottom line, aren't going to scale. And so you really have to find kind of that appropriate combination for a digital health kind of AI driven device software to be able to scale. And I think that is the holy grail that everybody's looking for right now and trying to find. So, voice to text technology took off as generative AI, right? Because that was an unmet need and people were kind of desperate for some sort of help, right? The fact that you're measuring at almost every practice how much time do clinicians spend writing their notes after bedtime? Like, that is an unmet need, and that's why this took off, and that's why it's scaling, and that's why there's actually also room for more than one or two companies. There are several companies that are succeeding. And so, what are those areas? I think that's the kind of important step moving forward, and I think it will be largely first, if we can get it right, population screening, earlier diagnosis, because at the end of the day, that's what keeps our patients safe, keeps them in the communities where they live, encourages them to use the secondary hospitals that are closing by the minute because people are all being sent to tertiary for reasons that they don't even know, right? And then allows the tertiary hospitals to have less high resource utilizing patients because they didn't come in urgently to us in the tertiary quaternary case. They were identified earlier. So I think that area is the most likely to work. Population screening and diagnosis earlier for whatever diagnosis it may be, because it improves patient outcome the whole way, but importantly, then improves activism in the community, right? Ability for people to stay in the community and actually, contribute economically. The use of secondary hospitals that are really at risk right now, and then the justified use of a tertiary hospital. And that's going to be fiscally a really great driver.
Yeah, yeah. So you bring together a lot of different kind of reasons, but or criteria like scale. Like it has to be also economic driver. It has to technology has to be ready, and of course the risk low. That's also whether it's something is used for diagnosis, or screening, or a treatment. That's very very different, right? And then also or something that improves the workflow or notes. And so now that I'm thinking about this, and you mentioned this notion of how will physicians adopt it and everyone will do it differently in the role of association. I was wondering whether associations will have like AI in specialty field as kind of a new when you go to a conference, like a new kind of interest, a new subcategory. I almost see that coming. So I was wondering whether there is a conversation actually at the ACC about that.
We already did it. We began several years ago. So every one of our tracks at our annual meeting, whether you're talking about EP or congenital heart disease or valve, generally has 1 to 2 AI lectures that's happening embedded in that track, right? So that's number one. Then we have AI intensives, which is, do you really want to deep dive this? Are you the person in your practice who's going to be the go-to? Apply and come and be part of this 3-hour AI intensive where you really learn kind of the basics of what's happening. And then, is there a level 2 AI intensive happening? And so we started doing that a couple years ago, and I think it's been really well received. The next step for us is the organization itself putting out information. So prompt generation guides. How do you work with an LLM? What is a good prompt? What is it, right? So for digital health, it's not specifically AI, but we created the Apple Watch guide. All patients were bringing in their Apple Watch tracings, reams of paper being used, right? Nobody knew what to do. And so just trying to start to create a little infrastructure around when digital health is happening, AI is happening, what are we seeing? How does it work? How can you try and make it infrastructure in your own practice? So I think there's practice focused kind of care transformation, and then there's education. And again, the education can't be separate. You can't silo it. You can have advanced courses, but you also need to recognize AI is in everything, so let's make sure that we're covering it there.
No, thanks for sharing that. Which brings me to the AI in education because when people say AI nowadays, everyone thinks of generative AI. I actually met you back in 2023 when we partnered. When I say we, I mean EverMed partnered with the ACC and launched ACC Anywhere, the Netflix style platform for cardiologists. And it's interesting when I met the ACC team at the time, education team, just 4 months before that, I learned that actually there was a vision that was brewing for about 10 years almost to have something like that. But it was not question of time, partner, technology being available, things like that. And it was launched in 2023. So can you share a little bit more about, why it was launched and how it is used today and anything on the
Yeah.
real reasons behind it?
So first of all, the ACC education team is phenomenal. The lifelong learning oversight committee of members is phenomenal, and they have been forward thinking since the beginning of time. When I was a fellow, I used to sit in that room, kind of listening actively to what's the next idea they're going to come up with because I know it's going to be great. So just kudos to them for everything. For ACC Anywhere, yes, the idea had been brewing for a long time. My colleagues Joyce Donnellan, Janice Sibley, and others, it really said, when we are, first of all, short form education, we've recognized for a long time is a necessity in medicine. Now, when I say short form, I don't mean you're going to learn everything in a like 30-second, TikTok. That's not what I'm talking about for short form. We can have that conversation on another day about social media, not today. However, this idea that when I watch something and I learn it, and it's not an hour, 2, 3 hour lecture, what happens next? What am I doing now? Right. And how do I figure out what I need after that? And so ACC Anywhere, and what a nice relationship, Everman and ACC had to do this, is this idea of exactly what you said, Netflix, which is if I'm learning about this, what are some other things that I might then be learning about that might be interesting to me? If Netflix can do it and can find exactly every rom com or adventure thing that I want to watch, right? And very nice, give me the next suggestion. Why can't I do that academically? Now, you can also importantly think about what if you want to not learn the thing you do every day, but you want to make sure that if you have gaps, you're doing that. And so our education team thinks a lot about not just teaching you the things adjacent to what you know, but how do I push your adjacencies to the areas where you may not be as strong based on testing you do other things. And so they're constantly always thinking about what are the products that we can create that help our clinicians become stronger clinicians, provide better outcomes, and recognize that not all adults learn the same way. And this is one thing I learned from, the ACC education team back when I was a fellow, which is all adults learn in different ways. So you have to have multimodality mechanisms. Not everybody is reading a journal article. So, what does a video do? What does a podcast do? What is a conversation with someone versus a lecture? When are you reading something? How important is a central illustration or figure? Very important. Lots of people are just straight up visual. And so I think all of that deserves credit. And in the future, hopefully we'll be able to figure out how to use AI across associations to say, here's what you are currently really good at. Here's what you're wanting to learn more about. Here are some gaps that may be relevant to your practice right now based on what we're seeing. Is there a possibility you could even see who's in someone's practice, not privacy wise, the exact people, but is there a possibility in the future there'll be de-identified data saying here are the diagnoses that are coming through your office, right? And then match those so like this is the kind of thing that I think in the future is going to be excited for any association to look at, really help our clinicians.
No, thanks for sharing that. And I think the first comment, I also when I hear micro learning, I just clarify this is not 15, 30 second social media in the context of like video learning. For example, we find in our data that it's about 19 minutes is the average session time. So we always say like if we create custom content, like up to 20 minutes, something sweet spot 12 to 20, but not an hour or 2 hour long, as you said. And that's where I go in, I learn, maybe I get partially a credit, come out and continue with my life, and I find it quickly. One notion that I still remember you mentioned when I talked to you in 2023 was this idea that algorithm not just looks at your past behavior or what you watch. Let's say the movies on Netflix I watched in the past or the videos on ACC Anywhere I watched in the past, but also be able to find the gaps or knowledge gaps in the future. And actually it did influence how we're thinking about an algorithm evolution and or algorithm tries to figure out where are the people like this person that and what are they watching next. So it's kind of almost the algorithm is a little bit ahead of you in terms of predicting what you would watch next. So yeah, so we
I
wanted
love
to ask you to
seeing
comment on
I
that.
love
Yeah,
seeing the smile on your face when you think about your being able to get that right, by the way. You just lit up when you started thinking about the ability to do that. I
yeah,
love it.
yeah. And we took honestly took inspiration from Netflix because that's a collaborative filtering as an AI technique that does that and is able to predict is really, really powerful. But I haven't thought about it in the context of a clinician until you brought it up.
Well, now it's time to. This is good. Now we have our next project together. That's right.
There you go. And anything that you see kind of in the future of I know ACC Anywhere had like 30,000 hours in the first year and there's more than 5,000 people joining. I think so far we have more than 2,000 surveys. I remember more than 2,000 surveys. I was surprised. I saw, okay, there's definitely a need for this. Like you mentioned, like voice to text. There's definitely a need, and it seems like one of the biggest drivers also is time. Help me find what I need quickly. Don't
I
let me
mean,
suffer through a
s-
bad user experience.
so time, user experience, and reliable information. And I think that's the thing that people are really worried about nowadays, right? How long it takes to find the right thing takes longer now because there are very convincing things out there that may not be the right one for me, may not be directly applicable. I made ChatGPT an answer, but gosh, I've got to go back and check what the references are to make sure that it wasn't a hallucination. Not that ChatGPT does anything wrong. Large language models have hallucination. That is, by definition part of it, which is why we're thinking about small language models and other things. But so all that to say, I think it is a responsibility for associations to be the ones who are culling through and providing the reliable data where when you come to whoever it may be, AAFP, gastroenterology, ASCO, ACC, any of us, when you come to us, you should be able to rely on the fact that we have done vetting, that we know what these algorithms are doing, that we understand where they're pulling from, that we're directing you to reliable information. Now, you as a clinician still can't ever blame the AI. It is a tool, and you are deciding to use it or not use it, just like any other tool. But gosh, wouldn't it be nice for them if we could be their reliable source always, the way we used to be when it was just books and journals?
Yeah, and one comment to that is for two comments. One, I'm actually hearing you what you say reliability, trust, and credible education and vetting. Like, I feel like trust, which is becoming more and more an issue because of an AI, but trust and trusted source of information combined with AI that can make, that trust education easier, more accessible, multimodal, as you said, I think is a powerful combo where I really feel excited about the future of associations in AI. And the other one that reminded me, if you were saying, I recently read on the history of medical associations. Why did they come about? And it's really like that same reason, which is mid 19th century. First AMA, I think, was the first one, was to prevent people claiming they're doctors who are not doctors, to set standards for medical schools half were closed in the 20 days after association happened. I feel like living that mission like 170 years later is even more important based on
I
what you
would
said.
love
So
for
it's
you to share whatever you read with me because that is so true, right? That is still our mission. It is the same mission we've had since the beginning. So I absolutely love that.
yeah, so great. Thank you so much for being the guest today, and we'll stay for half more minutes so it all gets uploaded. And thank you.
Absolutely. Thanks for having me.